The treatment of HIV patients co-infected with HCV has been historically difficult because treatment response rates have been historically poorer, especially in the older treatment modalities with interferon and ribavirin-based therapies. Then came along the DAAs, the first of which were introduced in 2011, and we had problems with what we call drug-drug interactions. In other words, the interactions between the hepatitis C-related medications and the HIV medications caused unwanted side effects that were problematic. And so, unfortunately, we were not able to treat large numbers of patients with HIV and HCV co-infection.
Almost 1/3 of HIV patients has an HCV, hepatitis C infection. Hepatitis C can lead to more disease progression and liver complication in co-infected patients. And several reports has shown more liver decompensation and liver cancer among HIV patients.
Now we have not one but multiple DAA combinations that are available that are actually FDA approved for use in the HCV co-infected population. We can treat patients both who are on therapy for their HIV as well as those patients who are not on therapy for their HIV for one reason or another. The DAAs now have very few drug interactions. There are some that providers do need to be aware about. But more and more as we move forward, in fact, I was just at the meeting at DDW last week, and there's a new DAA coming out called the Cladosphere that has virtually no interactions with any of the HIV medications.
In the area of direct antiviral treatment, we have plenty of medication we can use to treat hepatitis C among HIV patients. And fortunately, the side effects controllable and non-comparable to the previous pegylated interferon and medication we used to use to treat hepatitis C among HIV patients. The treatment's really not that different between the mono-infected or co-infected. We use similar medication and we have similar success rate. However, in co-infected patient, we have to pay more attention to drug-to-drug interaction and drug toxicity.
Moving forward, I think what we have done is reclassified the HIV-HCV co-infected population as no longer being qualified as a special population. We call them just standard patients, and we treat them with the standard algorithms that we would use for any patient who does not have HIV infection as well.
Currently, we recommend hepatitis C to be checked in all HIV patients. Hepatitis C treatment should be considered in all HIV patients unless if there's a clear medical contraindication.